To Pharma Life, let's discuss about peptic ulcer. So, peptic ulcer. Peptic ulcer is nothing but ulceration in the muscularis mucosa. There are three forms of peptic ulcer, that is NSAID induced, Helicobacter associated peptic ulcer, stress ulcers. Stress ulcers are commonly termed as stress related mucosal damage. It ranges from mucosal lesions on the superficial layers to the deep ulcers. So, if the ulcers are occurring frequently, it is termed as chronic PUD. PUD means peptic ulcer disease. So, after treating with anti-ulcer regimen, within 1 year, 60 to 100% ulcers reoccur. This is due to because of HP infection, NSAID use, non-compliance to the medication, gastric acid hypersecretion, cigarette smoke, alcohol use, etc. So, ulceration occurs mostly in the stomach and duodenum. So, stomach ulcers are termed as gastric ulcers, duodenum ulcers are called duodenal ulcers. So, ulcerations rarely occur in esophagus, ileum and colon. So, etiology. Coming to etiology, HP, NSAIDs and all other etiological factors disturb the normal healing mechanism that causes peptic ulcer in presence of acid and pepsin. So gastric ulcer mostly occur anywhere in the stomach but mostly on the lesser curvature of stomach. Duodenal ulcers occur in the first part of duodenum. So prevalence of ulcers mostly occur in older adults because of their increased use of NSAIDs. Incidence of ulcer occurrence varies from ulcer type, age, gender, geographic location. Age. Duodenal ulcers occur within the age of 30 to 40 years and gastric ulcers occur after the age of 50 years. Females are more prone to ulceration. So, main etiological factor is Helicobacter. Helicobacter infected individuals, mostly 20% of the people develop symptomatic peptic ulcer disease. All non-NSAID ulcers are of due to HP infection. Eradication of HP decreases ulcer reoccurrences and its related complications. HP can be transmitted from fecal oral routes. Risk factors for HP infection include living in crowded area, unhygienic conditions, etc. Prevalence of HP varies by geographic location, socio-economic conditions and age. So NSAIDs are nothing but non-steroidal anti-inflammatory drugs. They are commonly prescribed drugs. So they are mostly prescribed drugs. Subepithelial hemorrhage occurs within 15 to 30 minutes of ingestion and that leads to gastric erosion. So gastroduodenal ulcers occur for the 13 to 50% of regular NSAID users. So gastric ulcers primarily occur in the atrium and they are potential to bleed and perforate. So another etiological factor is cigarette smoking. The exact mechanism of cigarette smoking is unknown, but possible mechanism include delayed gastric emptying and decreased mucosal production, prostaglandin production. Stress may worsen PUD, but it's not the cause of peptic ulcer. Dietary factors also have influence on the peptic ulcer. So caffeine, the constituent of coffee is a gastric acid stimulant, and tea, coffee, beer, wine, these are all increased gastric acid secretions. So high concentration of alcohol ingestion cause acute mucosal damage and upper GI bleeding. So coming to pathophysiology, all the etiological factors, how it's influencing the peptic ulcer disease is all about pathophysiology. Next, imbalance. There is an imbalance between aggressive factors and defensive factors. There is increase of aggressive factors and decrease in defensive factors leads to the formation of peptic ulcer. Aggressive factors include gastric acid, pepsin, H. pylori, NSAID, smoking and alcohol. And defensive factors includes bicarbonates, mucus layer, prostaglandins, mucosal blood flow, epithelial renewal. All these factors include defensive factors. All these include aggressive factors. When there is an imbalance between these two, leads to the formation of peptic ulcers. Let's go into detail about one by one factor. Now we'll discuss about aggressive factors. Aggressive factors, firstly we'll discuss about gastric acid and pepsin secretion. So gastric acid and pepsin increased secretion leads to mucosal damage. So HCl is a gastric acid that is secreted by the parietal cells of stomach. This causes the increase in HCl secretion causes disruption of mucosal integrity. So coming to pepsinogen. Pepsinogen is an inactive precursor of pepsin. So this pepsinogen gets activated at acidic pH and inactivates reversibly at pH 4 and inactivates irreversibly at pH 7. So pepsin plays a proteolytic role in ulcer formation. So gastric acid and pepsin are the main reasons for the mucosal damage. So Helicobacter. Helicobacter or HP is a spiral shaped pH sensitive gram negative bacterium that will be present between mucus layer and epithelial cells. So this HP produces large amount of urease. This urease is hydrolyzed into urea and gastric juice. And this ammonia, so ammonia, urea is further converted to ammonia. So this ammonia creates neutral environment and protect the HP from acid. So it also produces acid inhibitory proteins, then it helps to adapt for low pH. It adheres to the epithelium and prevents from shedding off during cell turnover and mucus section. In this way, the HP is residing in the gastric and duodenal mucosal layers and causing the peptic ulcers. And another common cause for a peptic ulcer is NSAIDs. NSAIDs are called non-steroidal anti-inflammatory drugs. They are mostly prescribed. So non-selective NSAIDs like aspirin cause mucosal damage. How they are causing mucosal damage is by two mechanisms. First is direct or topical irritation of gastric epithelium or systemic inhibition of endogenous mucosal prostaglandin production. This second step is causing peptic ulcer. This second step plays a major role in causing of peptic ulcer. So arachidonic acid is converted to prostaglandins. This is inhibited by COX. This is helpful by COX. This COX inhibition causes decrease in production of prostaglandins. So COX-1 is expressed in stomach, kidney, intestine, platelets, etc. COX-2 is undetected in normal physiological condition and detected only in the inflammation condition. COX-1 is helpful for the production of prostaglandins that regulate the normal physiologic process like GI mucosal integrity, platelet homeostasis and renal function. So COX-2 is helpful for inflammatory stimuli, cytokines and produce prostaglandins that help in the inflammation of pain and fever. Adverse effects are due to inhibition of COX-1. So selective COX-2 inhibitors should be prescribed to avoid the peptic ulcer and related GI effects. Non-selective NSAIDs inhibit both COX-1 and COX-2, and this irreversibly inhibits COX-1 platelet COX-1 for 18 hours, thus causes decrease in platelet aggregation and prolongs the bleeding time. Neutrophil adherence causes the damage to vascular endothelium and decreases mucosal blood flow. So all these about the aggressive factors. Now coming to defensive factors. Mucosal defense and repair mechanism. Mucosal defense and repair mechanism protect the gastroduodenal mucosa. Gastroduodenal mucosa is protected from exogenous endogenous toxins by the mucosal defense and repair mechanism. Mucosal defense include bicarbonates, mucus, intrinsic epithelial cell defense, mucosal blood flow. All these factors constitute mucosal defense. Next, viscous nature and near neutral pH of mucous bicarbonate protects the stomach from acidic contents. So mucosal repair includes epithelial cell restitution, growth and regeneration. So mucosal integrity and repair is maintained by endogenous prostaglandin production. Because of this mucosal integrity and repair, it can withdraw the effects of irritants. So alteration in the mucosal defense and repair system leads to the formation of peptic ulcer. This is all about the etiology and pathophysiology of peptic ulcer.